This presentation will discuss the geriatric syndrome of falls. What is the definition of a fall? According to the Agency for Healthcare Research and Quality, a patient fall is defined as an unplanned descent to the floor with or without injury to the patient. According to the World Health Organization, a fall is defined as an event which results in a person coming to rest inadvertently on the ground or floor or other level. The background and significance of falls. Falls are the second leading cause of accidental or unintentional injury deaths worldwide. Adults older than 65 years of age suffer the greatest number of fatal falls. Older people have the highest risk of death or serious injury arising from a fall, and the risk increases with age. In the United States, 20 to 30% of older people who fall suffer moderate to severe injuries such as bruises, hip fractures, or head trauma. Older adults are at increased risk due to physical, sensory, and cognitive changes associated with aging in combination with environments that are not adapted for an aging population. Nursing implications for falls. Prevention strategies should emphasize education, training, creating safer environments, prioritizing fall-related research, and establishing effective policies to reduce risk. 1 in 4 older adults 65 years or older fall each year. Every 20 minutes in the United States, an older adult dies from a fall, and the healthcare cost for falls is insurmountable. There's approximately $50 billion in healthcare costs annually related to falls. $9 billion for Medicaid, $12 billion for private pay or out-of-pocket insurances, and $29 billion for Medicare. Elderly presentations for falls include minor injuries such as bruises, abrasions, and lacerations. Furthermore, approximately 10% of all falls in seniors cause major injuries, including intracranial injuries and fractures. 1% of all falls in this population result in hip fractures, which pose a significant risk for post-fall morbidity and mortality. For this case study, I used WJ, who is a 95-year-old Caucasian male. He presented to the office with his son for routine follow-up of chronic medical conditions. His son did report that he fell and his collarbone had been hurting him some. Patient admitted that he did fall while pushing his walker and getting tripped up on a scatter rug. He denied any dizziness or lightheadedness prior to or after the fall. He does wear a medical alert bracelet, but this was not activated as his son was home at the time of the incident. In regards to his collarbone, the patient stated that it didn't hurt very much and it was not bothering him. The patient reports no known food or drug allergies. He is up to date with the Prevnar 13 pneumonia vaccination, but he refuses annual flu vaccines. His past medical history is significant for hypertension, hyperlipidemia, insomnia, depression, COPD, osteoarthritis of the left knee. His surgical history includes an appendectomy and a cholecystectomy. He currently resides with his son in a stable environment. His current medications include Lasix 40 milligrams by mouth daily, Prenavil 40 milligrams by mouth daily, Norco 7.5-3 to 25 milligrams twice a day for pain, Zoloft 50 milligrams daily, Zocor 20 milligrams daily, and Ambien 10 milligrams at night. A complete review of systems was performed with the patient that included pertinent positives and negatives. The patient denied any dizziness, lightheadedness, headache, or visual changes. He did not have any chest pain, palpitations, or syncope. He is short of breath on exertion, and he wears continuous O2 therapy at 3 liters per minute via nasal cannula. He is positive for left knee pain and uses a copper knee brace and also ambulates with a rolling walker. He denied any numbness, tingling, or paresthesias in his bilateral or bilateral lower upper extremities, positive for intermittent loss of balance. Upon checking his vital signs, the patient is 65 inches tall. He weighed 172 pounds. His BMI is 28.6. Blood pressure was 158/86. His heart rate was 79. His temperature was 98.4, and his O2 saturation was 96% on 3 liters of oxygen. His respiratory rate was 20. Upon physical exam of the patient, he was well developed, overweight, and appeared in no acute distress. His heart rate was regular with audible S1 and S2. No murmurs, gallops, or rubs were noted. For HEENT, no significant findings. There was ectropion of his left lower lid. His bilateral tympanic membranes were pearly gray with light reflex noted. There was some scarring present on the left tympanic membrane and a small amount of yellow cerumen present in canal bilaterally. Respiratory, he has decreased lung sounds bilaterally as he was a history of a previous smoker. No use of accessory muscles or retractions noted. There was no rhonchiales or wheezing either. Musculoskeletal, he does have tenderness of left knee and across bony prominence of left clavicle upon palpation, decreased range of motion of left knee, and he is ambulating with a rolling walker. Neurovascular, he did have a positive Romberg test, but had no abnormal reflexes. Integumentary, he did have scattered bruising on his upper and lower extremities bilaterally. There was no bruising at the side of left clavicle. No abrasions or lacerations were noted. There were screening tools implemented during this patient encounter that included a home safety assessment checklist. Him and his son are to complete this and return it at the next follow-up visit. This was chosen due to the use of scatter rugs in the home and concerns of patient safety. The frailty assessment was utilized as well, and he scored a 4, which indicates that he is frail. A depression screening tool was used, which was the Geriatric Depression Scale, the short form. He scored a 5, which is suggestive for mild depression, and he does have a history of depression and is stable on Zoloft. A mini mental status examination was performed. He scored a 25, which indicated no cognitive impairment. A Tenetti balance assessment tool was also conducted in the office. He scored 10 out of 28, which is indicative of high risk for falls. Labs to consider for this patient include vitamin B12. Vitamin B12 deficiency can cause poor balance, numbness, and tingling that may result in gait disturbance. A vitamin D hydroxy should also be obtained because deficiency may lead to thin, brittle, and porous bones, and also muscle weakness is common with vitamin D deficiency. A BMP should be ordered to evaluate electrolyte deficiencies and glucose levels, which could contribute to falls, and also a urinalysis to evaluate for infection and hydration status. Diagnostics to order include orthostatic vital signs and an x-ray of the left clavicle. Health maintenance and disease prevention for this patient. Age-related health maintenance for 95-year-old male would include cognitive impairment screening. The United States Preventative Service Task Force concludes that current evidence is insufficient to assess the balance and benefits of screening for cognitive impairment. A depression screening, this is recommended in the general adult population and also those that are increased risk of chronic illnesses, which Mr. JM would be. Screening and home monitoring of blood pressure. The United States Preventive Services Task Force recommends annual screening for adults aged 40 years and older for those at increased risk for high blood pressure, and he does have a history of hypertension. Fall prevention in community dwelling older adults. Weight-bearing exercise is identified for those for increased risk of fall because it can increase stamina and balance. The plan study, which is stopping elderly accidents, deaths, and injuries algorithm, which is seen on the right. This is like a thorough assessment for a fall. It's a comprehensive assessment that you can use with your patients, and it has been shown to decrease the risk of falls and helps you to identify whether they're at risk for low risk, moderate, or high risk falls. In addition to the algorithm on the right, you should consider medication modifications and a reduction in polypharmacy, and also environmental modifications. For this patient, he does have scatter rugs in the home, and that was discussed with him and his son that they either needed to be secured to the floor or removed. Furthermore, a 2012 Cochrane systematic review reported that clinical assessment by a healthcare provider combined with individualized treatment of identified risk factors, referral if needed, and follow-up reduced the rate of falls by 24%. A fall risk assessment is also required as part of the Welcome to Medicare examination, and a fall-focused physical exam should be conducted on all individuals that are high risk for falls or with previous history of falls. A physical exam should include orthostatic vital signs, distance, visual acuity, cardiac examination for rate, rhythm, and murmurs, gait and balance evaluation, musculoskeletal examination of back and lower extremities, neurologic examination, cognitive screen, sensation, proprioception, muscle bulk, tone, strength, reflexes, and range of motion. Furthermore, it is recommended that evaluations include the timed get up and go test, the 30-second chair stand, and 4-stage balance. Differential diagnosis for this patient include orthostatic hypotension, which was ruled out by obtaining orthostatic vital signs and observing for dizziness and tachycardia. Additionally, dehydration was ruled out by obtaining a BMP and urinalysis that revealed that he was not dehydrated. Heart rhythm disturbance can be ruled out by obtaining EKG and auscultation of heart sounds, and vertigo may be ruled out by performing the Dix-Hallpike maneuver in the office to observe for nystagmus. The final diagnosis for this patient was accident due to mechanical fall without injury. Per the patient and the son, the patient fell by tripping over a scatter rug in the home while using his rolling walker. There was absence of injuries upon physical examination and a negative x-ray of left clavicle. Challenges and barriers of this plan: medication changes due to chronic medical problems presents an issue, and also environmental modifications because I was unable to determine home safety revisions. Community sources that are needed for this patient: evidence-based community fall prevention programs such as A Matter of Balance, Tai Chi for arthritis, and YMCA can be beneficial for patients in this population. An outpatient occupational therapist. This would include therapeutic activity that assists with functional task and task stimulation, therapeutic exercises, training in the use of adaptive techniques and equipment, and use of physical agent modalities. Furthermore, an outpatient physical therapist could initiate the Autogo exercise program, which is an individualized balance and strength fall prevention program delivered by a physical therapist in the home over 52 weeks. This is best suited for individuals who are frail with a fall history and difficulty with gait, balance, or leg strength, and that's why this was chosen for this patient. There were positive health behaviors identified for this patient, which included that he wears a medical alert bracelet, he uses a rolling walker to aid in ambulation, and he is compliant with continuous oxygen use. Negative health behaviors identified included scatter rugs in the home and that he refuses his annual flu vaccine. There were no socioeconomic or cultural determinants identified that affect this patient. Patient resides with son who provides a stable environment with adequate access to food, electricity, running water, and appropriate health care. Legal issues: his son is his power of. In conclusion, it is best to seek a multidisciplinary approach to enhance fall prevention in the older adult population, such as consulting with a physical therapist or occupational therapist. Furthermore, conducting a comprehensive fall risk assessment on all individuals age 65 or older will decrease the incidence of falls. And additionally, consider the evaluation of a B12 in older adults with a positive fall history, as symptoms of B12 deficiency include a weakness, numbness, and poor balance that can result in gait disturbance leading to fall.